Sir, I am Dr. Kaviprabha, final year surgery postgraduate in Coimbatore Medical College. I thank Professor Dr. Srinivasan sir for giving me this opportunity and encouraging me to do this. My case, 60-year-old lady came from E-Road with complaints of yellowish discoloration of eyes and urine for past 4 months. History of presenting illness. She was apparently well 4 months back. Then she noticed yellowish discoloration of eyes and urine, which is gradual in onset. Intensity of discoloration progressively increased for a period of 4 months. History of passage of pale colored stools present. History of itching present all over the body. History of vomiting present for the past 1 month. She had 2 to 3 episodes per day, which was non-bilious, not bloodstained. Contains undigested food particles, which was ingested 12 hours back. History of abdominal pain present for past 1 month. Insidious in onset. Dull aching type, which was more on upper abdomen. Not related to food intake. No aggravating, no relieving factors. History of loss of appetite present for past 4 months. And she had history of loss of weight for past 4 months. No history of passage of black tarry stools. No history of hematemesis. No history of fever with chills and rigors. No history of abdominal distension. No history of breathlessness, hemoptysis, cough. No history of headache, seizure, dizziness. Past history. No history of recurrent episodes of abdominal pain, jaundice, fever in the past. She is known hypertensive for past 2 years, for which she is on antihypertensive medication. No history of any other blood transfusion in her past. Personal history. She takes mixed diet. Appetite was reduced. Sleep disturbed. Her bowel and bladder habits normal. She's not an alcoholic, not a smoker. There is no any other substance abuse was present. Obstetric history. She had 4 female children. She is a postmenopausal lady. Family history, nil significant. Summarizing my case. 60-year-old postmenopausal lady came with yellowish discoloration of eyes and urine for past 4 months, progressing gradually, associated with passage of pale colored stools and pruritus all over the body. History of vomiting for past 1 month, contains undigested food particles. History of upper abdomen pain for past 1 month, which was dull aching type with loss of appetite and significant loss of weight. With this, my probable diagnosis, obstructive jaundice, most probably due to malignant etiology.
No, you carry on. You carry on with the examination, you will come to the discussion.
Yes, sir.
Ask her to present fully, sir.
Yeah.
Please.
Yes, sir. Her general physical examination with proper consent, with I explained the whole procedure to the patient, and then with the female chaperone, I examined the patient conscious oriented, moderately built and nourished. Her vital signs: pulse rate 80 beats per minute, regular in rhythm, normal in volume. Blood pressure 140/80 millimeter mercury, taken in right arm at sitting posture. Her weight is 56 kg and height 146 centimeter. Her BMI 26.2. Her ECOG score is 1. She is ectric, pallor could not be assessed, scratch marks seen all over the body, no bilateral pitting pedal edema present, no generalized lymphadenopathy, no signs of reversal failure present. Periabdominal examination. With proper consent, I stripped the patient from nipple to mid-thigh level. Inspectory findings: umbilicus normally inverted, abdomen not distended, no localized fullness seen, no visible pulsation seen. Suprapubic scar of size 2 cm noted, which healed by primary intention. No dilated vein seen. No, all quadrants moves equally with respiration. No visible gastric bed cells is seen. Inguinal orifices free. Palpation. On palpation, no localized rise in temperature noted over all quadrants of abdomen. Tenderness felt over the epigastric region. A well-defined globular mass of size 6 cm into 5 cm palpable over right hypochondriac region and right lumbar region, which has smooth surface, well-defined margin, firm in consistency, moves with respiration. Its lower, medial, and lateral border were palpable. Side-to-side mobility was noted. Can insinuate finger below the right costal margin. No other mass palpable. Liver not palpable. No splenomegaly. No renal angle tenderness. On percussion, dull note over the mass present, which was continuous with the liver dullness. No shifting dullness. No fluid thrill. Liver span is about 12 cm in clavicular line. On auscultation, normal bowel sounds here. No bruit or venous hum over the mass here. On auscultative percussion test, greater curvature of stomach marked just below the level of umbilicus. Succussion plus present. Pervaginal parectal examination normal. No left supraclavicular lymph node enlargement noted. Examination of other system. CVS S1 S2 present. RS bilateral normal vesicular breathsound present. CNS clinically normal. My probable summarizing my case. 60-year-old female presenting with complaints of ileous discretion of eyes and urine for past 4 months, progressing gradually, associated with pale color, passage of pale color stools and pruritus all over the body, history of vomiting for past 1 month, and history of abdominal pain for past 1 month. On examining patient, a well-defined globular mass felt in the right hypochondriac right lumbar region, likely to be gallbladder, with positive auscultar percussion test and succussion splash. My probable diagnosis: obstructive jaundice due to carcinoma head of pancreas with gastric outlet obstruction, probably due to duodenal involvement.
Okay, Kaviprabha, it's a very good presentation.
Yes, ma'am. Thank you, ma'am.
So can you go to the first slide? We will start discussion from the first slide.
Okay, so the only complaint is ileous eyes and urine. Good enough. Next, history of present illness.
Yes, sir.
You see, once you have jaundice, these jaundice may be of different patterns.
Yes, sir.
And from the history, we can make out what may be the likely cause of that jaundice.
Yes, sir.
First of all, it would like to differentiate whether the jaundice is likely to be some medical cause for jaundice or surgical jaundice. That is the first thing you should differentiate. So in the history of jaundice, is to start with the comment, how do you differentiate a jaundice history for a viral hepatitis from surgical jaundice? What are the specific point you should ask?
Sir, in surgical jaundice, there will be passage of pale color stools present, sir. In obstructive jaundice,
How is the onset? Suppose it's a viral hepatitis, how is the onset? Because you have to specifically ask those questions.
Yeah.
If it's a viral hepatitis, there are some phases.
yes, sir.
There is a phase called anicheric phase. In that
Yes, sir.
phase, patient has some symptoms which are very specific.
Prodromal
Patient has
symptoms will be
what?
there. Sir.
Tell me. What are the
Prodromal symptoms where they
yes,
will be there.
what are the important
Fever, malaise,
yes, fever, malaise, and
anorexia,
yes, severe anorexia, then arthralgia. Some
arthralgia.
patient may have skin rash. So if we
Yes.
have taken this part of the history, we can start saying patient does not have any prodromal symptoms preceding the onset of jaundice. So in one line, we are excluding that this is unlikely to be the viral hepatitis. Because if you see the viral hepatitis course, at one point of time, there may be a phase of intrahepatic cholestasis when you may have some itching, when you may have clay cholesterol for transient period. So the onset of jaundice is important. And in some cases, suppose patient has got choledocholithiasis, what may be the preceding symptom before the jaundice starts?
Pain, sir.
Yes. And
Colicky
how is the
type.
pain? How is that pain?
Intermittent colicky type of pain, sir.
Yes. It's a very severe, it's a biliary colic. So if you have a patient who has got history of severe colic pain and then the jaundice starts, it may be pointing towards stone disease. So there are a few things we should exclude at the beginning, saying that there is no prodromal symptom presence of jaundice, there is no history of any colic pain before the jaundice started, and rest of the jaundice history is fine. So once you have gone through this history of jaundice, you should cover whatever you have mentioned is right, stool color and the itching. Next is, this is a patient who has got a features of outer obstruction, which you have very clearly made out.
Just 1 second, Kaviprabha,
Yes,
I will differ with you in case of presenting the case. Okay. So see, the patient has come to you with the chief complaint. In the chief complaint, you have only written the jaundice. Okay. But usually with the jaundice, the itching and everything, it is so severe that the patient, whenever the patient comes, they always complain of jaundice along with the itching. Okay. So
Yes,
it's preferable if you keep the jaundice, the itching, and also this patient is the patient is complaining of vomiting, okay, which is around 2 to 3 episodes per day, and that means it's a kind of a severe disease, right?
Yes,
That the patient is having this kind of complaint. So all this, it should go to just one
Chief
line, but it should go to the chief complaint, and your
Okay.
chief complaint should be in the chronological order. You should write that the patient complaining of jaundice, this duration, itching, this duration, and see, the patient has also told you pale colored stool. If the patient has told you from her own, that should come to chief complaint. Okay. And also you have written the patient has vomiting, and also the patient has abdominal pain. These 4 points, it forms the basis of this obstructive jaundice case. Okay. So all these important relevant complaints, it should go to your chief complaint, and after that you should explain what are the symptoms are. Okay.
Okay, ma'am.
So one thing that you have written, that this patient, she had this Euler's discoloration of eyes and urine. Did she notice of her own, or it was noticed by someone else? Because usually when the patient comes, they gives us a history that they told me that I was turning yellow.
Ma'am, patient told patient chief complaint is yellowish excretion of urine only, ma'am. Her neighborhoods told yellowish excretion of eyes, ma'am.
Okay, okay,
She
no
clearly
problem.
told.
So okay, so in this thing, I would like to ask you, what are the kinds of jaundice you know of?
Ma'am, it is
What
a
are the kinds
surgical.
of jaundice?
Ma'am, surgical jaundice and it is subdivided into pre-hepatic, hepatic, and post-hepatic types, ma'am. In post-hepatic type, it is due to it is also called a surgical jaundice, ma'am.
Okay. So
Post-hepatic type.
why it is called a surgical jaundice?
The jaundice that can be corrected surgically.
Yeah.
So
Surgical
it
or
is
any
called
intervention. Okay. Surgical
intervention.
jaundice, in the jaundice can be corrected by surgery or any intervention. Okay. So can you differentiate hemolytic, hepatic, and obstructive jaundice on the basis of your history and your clinical examination?
Yes, ma'am, we can differentiate it, ma'am.
Okay. So let's start with urine.
In hemolytic jaundice, in hemolytic jaundice, in hepatic jaundice, and the post-hepatic jaundice, all three will have a yellowish discoloration of urine and eyes, ma'am.
Okay. What is the main difference? That in obstructive jaundice, you won't find urobilinogen in the urine. Okay.
Urine, ma'am. Yes, ma'am.
Yes.
It's due to bilirubin, ma'am.
Yeah.
Yellowish urine due to
Yes.
bilirubin, ma'am.
Okay. What about the stool?
Pale color stool will present only in obstructive jaundice, ma'am. In other two types, there won't be any pale color stool passage, ma'am.
Okay. So just now sir had told you that in case of a hepatic jaundice, which can be due to hepatitis, there can be a phase of cholestasis. Okay. So you can say there can be pale color stool in hepatitis, but that can be seen in the cholestatic phase. Okay. So
Okay.
what about the color of jaundice? It is very subjective, but for the sake of asking, in hemolytic, hepatic, and this obstructive?
Obstructive jaundice, it is yellowish orange in color, ma'am.
Yeah, it's orangish yellow or muddy. Okay. Whereas in hemolytic and hepatic, you will get a lighter yellow color of urine.
Ma'am.
Okay.
Yes,
and what about pruritus?
In obstructive jaundice, pruritus will be present all over the body, ma'am.
Okay.
And other cases, there won't be any pruritus, ma'am.
Hepatic jaundice, it can be present during the phase of cholestasis. What about the liver? You tell me on examination, what will you find in liver in this three, and what about spleen in this three?
I mean, in cholestatic stage of hepatitis, there will be enlargement of liver, ma'am. With obstructive jaundice also, if cholestasis develops with intrahepatic biliary radical dilatation, the patient will have liver enlargement, ma'am.
Okay. So in hemolytic jaundice, the
hemolytic jaundice, spleen also can be enlarged.
In hemolytic jaundice, usually the spleen is palpable, the liver is mildly enlarged, but most of the time it does not have any stigmata of liver cell failure. Okay. Whereas in the hepatic jaundice, it is always the liver will be tender. Okay. So to understand, if it's due to hepatitis or any infective cause which is in the liver, so there will be sometimes tender hepatomegaly. Okay. Whereas in case of this obstructive jaundice, there can be two ways. Once you can find a enlarged liver. What is the cause of enlarged liver in cholestasis, in obstructive jaundice?
Due to cholestasis, ma'am.
And why it causes?
Ma'am, it causes stasis of bile within the liver, and then
and the condition is called hydrohepatosis. Okay?
Hydrohepatosis.
Yeah, that's why you can palpate what is the typical finding of a liver in case of a cholestasis. How will you find the liver margin and everything?
Liver margin is sharp, well defined in the cholestatic type, ma'am.
It is firm and non-tender. Okay.
Non-tender. Yes,
and what about if it's a if you are finding any query of malignancy? How will the liver feel?
It will be irregular, ma'am. Irregular,
It
hard
can be
in
irregular with a nodular feeling. Okay. Okay.
Next slide. Turn to next slide.
Yes, sir.
Yeah. So if you have a diagnosis in mind of carcinoma head pancreas,
Yes, yes, sir.
there might be other causes of such obstructive jaundice. So in which type of obstructive jaundice you may have a history of melena or the black tarry stools?
So in periampullary carcinoma in periampullary carcinoma, the patient will have melena, sir.
You asked about fever with chills and rigors. What
Yes,
is the
sir.
idea to have this query?
If the patient is having cholangitis,
Yeah.
I want to rule out the cholangitis, sir. Hence, I ask this question,
So
sir.
if you think of a patient who has got stone disease versus
Yes,
a patient who has got a malignant obstructive jaundice,
yes,
in
sir.
which type of obstructive jaundice you expect that patient will have more instances of cholangitis?
Sir, in a patient with CBD stone only, the patient have cholangitic features, sir.
Why? Why patient having stone disease, both are obstructive jaundice, but
Yes, sir.
patient having stone disease, the incidence of cholangitis is more than patient having malignant obstruction. What is the reason behind?
So recurrent attacks of inflammation and fibrosis will be there in stone variety, sir. It
Once you
won't
have
be there
stone
in
disease, what is the background? What is the background of stone formation in gallbladder, migraine, the CBD? What is the background? Background is one of
infection,
the
sir.
component for development of stones is infection.
Yes, sir.
So the stone may contain a nidus of infection, and once that stone migrate to the bile duct, the chance of cholangitis is more. So if you have more instance of cholangitis, you think that this might be a stone disease rather than, but even in malignancy, there may be cholangitis. But what I'm trying to say is the cholangitis is more common in case of stone disease.
Yes,
Okay. So you have asked about the metastatic symptoms.
yes, sir.
We talked about lung and the neural.
Neural
Where else
component.
metastasis may occur from carcinoma pancreas?
So carcinoma.
How, what may be the other metastatic symptoms?
So there may be bone pain,
Yeah,
recent onset of backache.
yeah. Okay, so good enough. Next.
Past history,
So
sir.
Kaviprabha,
Yes, ma'am.
just go back to the negative history. So when you're writing the negative history like that, you have to complete one system at a time. Okay. So in
Yes,
one line, you have to complete chest pain, cough, hemoptysis, breathlessness. Other point, you have to write the loin pain, hematuria, hesitancy, urgency, headache. All this point you have to rule out. Okay. You can't leave anything because it's the safe for the sake of completion. Okay.
yes, ma'am.
And one thing is, why do you get this why have you taken this history of black tardy stool? When does it happen and why?
Ma'am, if it is a periampullary type, the mucosa will slough out and it will produce bleeding, ma'am. And upper gastrointestinal bleeding will present as melena, ma'am. That is blackish tarry stools, ma'am. So
Okay.
I asked this history, ma'am.
Okay, so do you know that there can be incidence of a silver colored stool? Why does it happen?
Yes, ma'am. If pale color stool and melena both combined, the silver paint stool or aluminum paint stool will occur, ma'am.
So why there is pruritus in case of obstructive jaundice in a jaundice patient?
In a jaundice patient, the bile salts will get deposited in the hair follicles of skin, ma'am.
Yeah,
It will induce the allergic reaction and then it will cause itching, ma'am.
yeah, it is usually due to
Reduce the
irritation
system.
of the nerve ending, which is situated in the dermis, which
Yes,
causes
ma'am.
this intense pruritus. Okay.
Yes, ma'am.
Okay.
Next,
Okay. Yeah.
next. Just personal history.
Yes, yes,
Uh,
sir.
what is the importance of taking this habit in patient who suspect a carcinoma pancreas? Is there any relevance of these personal habits to malignancy in the pancreas?
So smoking is a predisposing factor, sir.
Yes. What about the alcohol?
Alcohol, I don't know, sir. No, sir.
Yes. Again, alcohol is also a
Risk
predisposing
factor.
because alcohol can cause pancreatitis, and this
Yes, sir.
patient of chronic pancreatitis has about 10 to 20-fold higher incidence of malignancy in the background of chronic pancreatitis. So these are
Yes.
important to assess whether the habit is related to the malignancy in the pancreas. What is the relation of diet to pancreatic malignancy?
Patients having more fatty diet will have increased risk of developing
Which type of diet is said to be protective for pancreatic malignancy?
high fiber diet, sir. High
Fiber
protein,
diet,
high fiber
fruits,
diet.
high
Fruit.
fiber diet and fruits said to, because they contain a lot of antioxidants.
Yes, sir.
Okay.
Okay.
Next.
You have written sleep is disturbed. Why is that? Because when you're writing sleep is disturbed in a jaundice patient, it can indicate a lot of things, right?
Yes. My patient is having intense pruritus, ma'am. Hence, she is having disturbed sleep, ma'am.
Yeah. So where else you can find disturbed sleep in case of jaundice?
Ma'am, if the patient is cirrhotic and if the patient is having hepatic encephalopathy, the sleep is disturbed, ma'am.
Yeah. There is a altered pattern of sleep that is noticed. Okay.
Yes, ma'am.
And when you're writing mixed diet, usually examiners from some places they say there is nothing called mixed diet. So you should mention whether it's a vegetarian or a non-vegetarian kind of diet. Okay.
Okay,
There
ma'am.
is nothing actually called mixed diet. Next slide.
Yes, ma'am.
What is the relevance of family history in patient having pancreatic malignancy? Is there any specific uh, reason to ask about the family background and any other disease in the family?
Sir, pancreatic neuroendocrine tumors can run in family, sir.
Apart from that, only neuroendocrine tumors?
And then,
What are BRCA2 gene related malignancies?
yes, sir, colon, pancreatic malignancy, and breast,
Yes. And prostate.
prostate.
Okay.
So what are the familial syndromes that can be associated with pancreatic malignancy?
Men syndrome, ma'am. Men syndrome.
In what I'm talking about pancreatic adenocarcinoma. Okay. Can you answer? Okay.
Don't
So
know,
there
ma'am.
can be cases of familial, say, pancreas in cases of familial pancreatitis, which includes mutations of the gene of PRSS1 and SPINK1. Okay. Other than
Yes,
that, it
ma'am.
can be seen in CDKN2A, which is the familial melanoma. Okay. And also it can be seen in Peutz-Jeghers syndrome. Okay. Which is due to STK11. And also it can be seen in BRCA2. The most common gene which is mutated in a familial carcinoma, it is BRCA2. And can you tell me what is the most common gene it is seen in a sporadic pancreas cancer? It is KRAS.
KRAS.
Okay, next.
Next. Next.
Okay,
Good enough.
so
You have given the details of the general examination and you have briefed it well. Next.
one sec. Come to the general survey. So, what is the significance of pulse? What can you expect in a jaundice patient?
Jaundice patient will have a relative bradycardia, ma'am, due
Because
to
of
bile salt deposition over the pacemaker cells, SI node or
yes,
AV
madam.
node.
Yes. So, what is the importance of the performance status when you're dealing with a case of, suppose I'm telling it's a case of CA pancreas. What is the importance of the ECOG score?
If the ECOG score is more, the patient will have advanced disease, ma'am.
So not only
Debilitated
advanced disease, but also performance status is taken into account while planning the treatment part.
surgery.
While
Yes, ma'am.
planning the surgery and also while deciding for the chemotherapy and other adjuvant or neoadjuvant therapy. Okay.
Yes,
Even
ma'am.
now you apply this for surgical fitness also.
Yes.
Earlier it was applied for chemotherapy fitness, but in surgical practice now you also rely on the performance status, either ECOG or Karnofsky score, because if someone who has got a performance score much lower down the line, they are not fit for even a surgical intervention. Okay.
Yes, sir.
So next.
One more question. As you
Yes,
have
ma'am.
said, the patient is deeply jaundiced. Okay. So can you assess the anemia in such a patient?
Ma'am, we couldn't assess the deeply anemia and deeply jaundice patient, ma'am.
Okay, so
Pale could not be assessed.
where can you look for jaundice in any failure when if the patient has a concurring jaundice?
There are some sites.
Tongue, we can assess. Pale tongue.
Tongue, lips.
Tongue, lips, nail beds. Okay,
Yes, ma'am.
these are the sites where we can look for failure. Okay.
You said there is no signs of liver failure.
Yes,
Yeah.
sir.
What we have looked for to assess that patient has no signs of liver failure?
From head
Clinical.
to toe, we should look for alopecia, and then palmar erythema, spider nevi, testicular atrophy. If it
The
is
female
male
patient.
patient, if
The female.
in female patient, bilateral parotid enlargement, and pedal edema, caput medusae.
Yeah. Okay.
While describing umbilicus, please tell its position, okay? Because as here from your history, we are now thinking, we have started to think that we are dealing with a malignant case, okay? So this is important because, can you say what is Tannian sign?
Daniels in ascites patient, the umbilicus is shifted to upper level, ma'am, and then in hepatomegaly or occupying lesion in upper abdomen, the umbilicus is shifted to lower side, ma'am.
So in
That is
case
called as Daniel sign.
of ascites, usually the umbilicus is shifted down, whereas any cause which is arising from the pelvis, like ovarian cyst or anything, the umbilicus is pushed up, okay? That is the significance. Okay. So you have written that there is no visible pulsation or any peristalsis.
Yes, ma'am.
In this patient where we have a history of vomiting and everything, do you expect such a swelling to be present?
Swelling
Or a
in gastric outlet obstruction, there.
gastric region? Okay, so
What is
how do we look for gastric peristalsis? How do we look for it?
Ma'am, we should watch for gastric peristalsis after asking the patient to drink of about 500 to 700 ml of fluid, and then ask the patient to lie down on the couch, and we should inspect tangentially at the level of bed to look for visible gastric peristalsis, ma'am.
Yeah.
what
So
is the
our eyes
characteristics?
should be at the level of the patient's abdomen. Okay.
Yes, ma'am.
What is the characteristics of a gastric peristaltic waves?
It
If these
should
are
be from
present, what are the characteristics of
left
these
to
waves?
right. Peristaltic wave should be from left to right, starting from left.
These are very large peristaltic waves, which moves from left hypochondriac towards the lumbar, umbilical,
Lumbar
and
and
towards the
umbilical.
right hypochondriac
Right
region. So
hypochondriac region.
this is the visible gastric peristaltic wave. Next slide, please. See, when you come to the postgraduate way of presentation, there are two ways of presenting. One is the way I've described the lump is good enough about the character of the lump. Or as a postgraduate, when you have satisfied that you have examined the patient and you have this character of the lump, you can straight away start saying gallbladder is enlarged and palpable.
Yes, sir.
This is the character. Let the examiner ask, why do you say this is gallbladder? You see, you have not commented about this lump at the end of your finding also. Now, if I ask, what do you think this lump is likely to be?
Sir, it is distended gallbladder, sir.
Gallbladder. Why?
Sir, it is globular well-defined mass which is situated in the gallbladder point, sir. It is lateral to the lateral border of rectus sheath and at the level of tip of ninth costal cartilage in transpyloric plane, sir. So, with
Why don't you can insinuate the finger below the right costal margin? If you have a gallbladder mass coming from the costal margin downward, this test is done to assess whether the lump is to the liver gallbladder or the lump is something below the costal margin from some organ. So even if a gallbladder mass liver is not enlarged, you will
liver
not be able to pass your finger between the lump and the costal margin because this lump is coming from the costal margin. So you need not comment about this unless liver is enlarged.
yes, sir.
And if the gallbladder is enlarged, you cannot do that at the point of gallbladder mass. And it is, if you have a lump of this dimension, try to understand the right hypochondriac area in the abdomen is a very small area, it's a thumb size area. So if lump of 6 centimeter, 5 centimeter, this lump will be extending onto the other regions, right? Lumbar, it can go to the umbilical, it can go medial to the rectus sheath also. So it may be a mass which is extended to the other areas of the abdomen, depending on the size of the gallbladder lump. Okay, so you can straightaway say that is a gallbladder what you are palpating, and this is a character. This particular lump you have described, what do you think is a is the gallbladder distended because of distal obstruction, or is the gallbladder mass because of a mass in the gallbladder itself? Can you make out some points?
Yes, sir. It is due to distal obstruction only, sir. If the tumor is arising from gallbladder, means the gallbladder will be hard in consistency, and it has irregular surface, sir. Or
Yes.
if the gallbladder mass in the neck of the gallbladder, it may produce the features like this, sir.
Yes. If you have a neck obstruction and then the whole gallbladder is appearing like a mucocele, this can be there. Otherwise, a patient who has got a mass in the gallbladder in the body or the fundus area, the character will be totally different. Okay. What is the importance of palpating spleen in a patient who has got obstructive jaundice and suspected carcinoma head pancreas? What is the importance of spleen palpation?
Sir, if the spleen is palpable in the case of obstructive jaundice, it
When?
it may be associated with the portal vein obstruction, sir.
Yes.
Splenic vein thrombosis, sir.
Yeah. It may be a pulmonary thrombosis or a mechanical obstruction by the tumor mass itself. In that case, you have splenomegaly. And in that case also, you can expect to find some collaterals. You said there is no liver failure in the form of some finding some collateral based abdominal wall. If there is a portal vein obstruction, you may have some collaterals opening the abdominal wall also. So that is important. You said there is no splenomegaly. Agreed. Next. How do you assess liver spleen on clinical examination?
Sir, first I will make the patient lie down on the couch, sir, and then I will start percuss from the right second intercostal space at mid-clavicular line, and then I will move laterally by percussing it, and the 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 conversion of tympanic, the dull node to tympanic node is marked at the lower level, sir. The difference between upper level and lower level is marked as liver span, sir.
Good enough.
What is the normal note of the chest? Percussion note of chest?
Resonant, ma'am.
So what is the normal liver span?
9 to 12 centimeter, ma'am.
Yeah. So if you have not got a shift in dullness, do you expect a fluid fill to be present?
Ma'am, fluid there will be present only in huge ascites, ma'am.
Yeah. So if you don't have a shift in dullness, you need not to mention that no fluid thrill, okay? Because it's obvious. Because shift in dullness is needed for a less amount of fluid. Okay. Okay.
Okay.
So
Diagnosis. Come to the diagnosis. Yeah.
a few questions from ausculto percussion. How do you do it, ausculto percussion, and how do you check for the succussion splash?
Ma'am, I will place my stethoscope over the epigastric region, ma'am, and then I will scratch with the pen or some elements from the starting from the left side, left hypochondriac region to uh, towards the right hypochondriac region, ma'am. The note change from the resonant note to dull note, disappearance of note is marked, ma'am.
Okay.
If it is below the level of umbilicus, it meant to be as a patient having gastric distension.
So while describing any of these techniques in case of examination, you should start with first I will ask consent from the patient. I will ask whether the patient is comfortable with me doing this examination. Okay. Next,
Okay.
there will be positioning of the patient, and if any special step is needed, like in case of a shifting blindness, we need to evacuate the bladder. In case of ausculto percussion, we need to evacuate the bladder. In case of a succussion splash, we should give the patient some fluid. Okay, so this kind of prerequisites you should mention. And in case of a succussion splash, it is checked with the diaphragm. Whereas ausculto percussion, we do it with the bell of the stethoscope. Okay, so these are the few very fine points, but you should know. And while describing a technique, okay.
Yes, ma'am.
So you have said, see, your provisional diagnosis is a little bit incomplete because see, when you're describing a case of jaundice, so you should mention about the condition of the liver cell. Okay, so you should write in your provisional diagnosis that this is a case of obstructive jaundice. You should mention the age of the patient. Okay, that is
Yes.
relevant. You should also see, you don't need to straight away point to carcinoma head of pancreas. It's very straightforward. Okay. So you can, what we can make out till now, ki it can be due to malignancy, right? We can point out ki it can be malignancy or it can be benign. Okay. So we can write ki which is due to malignancy with a clinically preserved liver function. Okay.
Yes.
That is, these are the few points that you should mention in a provisional diagnosis, and if any comorbidity which is present. Can you tell me any specific comorbidity which is relevant in case of CA pancreas?
Diabetes, ma'am.
Okay, so what is the importance of diabetes? If it's a long-standing
5%.
diabetes or it's early onset diabetes?
Early onset diabetes indicates
You understand the question well. What is the importance of diabetes? Recent onset of
diabetes denotes some abnormality in the pancreas, ma'am, like malignancy.
So
Is that
elderly
a-
patient, recent onset, you should think of that there might be any pathology which is arising from the pancreas. Whereas if it's a case of long-standing diabetes, it's a independent risk factor for CA pancreas. Okay.
Yes, ma'am.
Okay.
particularly type 2 diabetes, not uh, type 1 diabetes. Type 2
Yes.
diabetes is a factor for malignancy in the pancreas. You said
Yes, sir.
it's a malignant obstructive jaundice. What are the points in favor of your saying that patient has got a malignant obstructive jaundice?
Sir, in history, the patient is having the loss of appetite and significant loss of weight, sir.
Before that, take the age of the patient.
She is
Very
old age
is
person,
it,
sir.
you want to say the malignant obstructive jaundice, number one, you have to exclude other benign causes. The elderly lady, number one. Number two, the history of this jaundice is what? For
4 months, sir.
very short duration.
Short
Patient
duration.
having Crohn's disease does not come to doctor with the first attack of pain. Patient has
Yes.
pain, jaundice relieved, and then maybe for some duration is there. So it's a short history of this, and associated with this, patient has significant history of loss of appetite and loss of weight. Third thing is patient has got definite evidence of gastric outlet obstruction. So that indicate that in addition to jaundice, patient has got some mechanical obstruction in the gut, which might be because of some local pathology.
Yes, sir.
Okay. And then on examination, you find that gallbladder is palpable. In that case, is another point maybe in favor.
Yes, sir.
What is Kurzweil's law in relation to this gallbladder palpability?
Yes, sir. In obstructive jaundice patient, if the gallbladder is palpable, yeah, it mostly due to carcinoma, not due to stone disease, sir.
Why?
Because the gallbladder would be fibrosed and shrunken in case of in case of
What
stone
exactly
disease,
what
sir.
Kurzweil's law is? If in obstructive jaundice gallbladder is palpable, it is unlikely to be due to cholelithiasis, because in that case gallbladder would have been fibrous by previous cholelithiasis. Good enough. Okay, so these are the reason for diagnosis. And why do you say this patient has got carcinoma head pancreas as the primary diagnosis?
The patient is having obstructive jaundice of shorter duration, and then patient is having gastric outlet obstructions, sir, due to.
That's good. Yes. What may be the
Okay.
other differential diagnosis? If you take the, you see, once you are going to malignant obstructive jaundice, don't come to a DD with a very rare or something which is very unknown situation. So just tell me what may be the close differential diagnosis in this patient.
The periampullary growth, sir.
Periampullary growth. What do you mean by periampullary growth?
Sir, it is the region of about 2 centimeter around the ampular region, sir.
So this will
It
include
includes ampulla,
yes,
distal CBD, and
yes,
then pancreas, sir.
pancreatic head within
Pancreatic head.
within
Within
centimeter of the ampulla,
2
2
centimeters.
centimeters.
and 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 periampullary duodenal
Periampullary region,
tumors.
duodenal wall.
Here are the 4 groups of tumors which you include in periampullary. What else may be the differential diagnosis in this patient? Carcinoma head, periampullary. What else? Any
Carcinoma
other
stomach, sir.
Yeah. See, you are keeping just the differentials. Okay, so differential can be anything. It can be a case of carcinoma stomach, and if they ask you, "Okay, why jaundice?" Then what will you say? Why jaundice?
No,
Carcinomas, if it's a case of carcinoma stomach, can you get jaundice?
yes, ma'am. If the metastatic node that causing obstruction to
So
port
there can be a metastatic node. Can it be a case of carcinoma gallbladder?
Yes, ma'am. It may be, ma'am.
It can be. Okay. So you have to keep your options open. So one thing, have you checked for the nutritional status in this patient? Did you mention in your general survey?
Yes, ma'am. I mentioned about BMI, ma'am.
Of what?
BMI.
No. So what are the methods of assessing nutrition and why it is important? And just tell me, what are the methods of examining nutrition in this patient?
BMI is one. I agree. BMI is
One
a
is BMI.
One is BMI, another one is mid-arm circumference and tricep fold thickness, ma'am. Tricep fold thickness to assess fat, subcutaneous fat level, ma'am, and then
Other?
mid-arm circumference to detect the muscle mass, ma'am. Protein, if there is any protein deficiency, the
Yeah,
mid-arm
these are the
circumference.
macronutrients. What about the micronutrients? What do you expect in a case of jaundice? Okay, so in a case of jaundice, usually there is a deficiency of fat-soluble vitamins. Okay, so in case of a jaundice patient, when you find there is there is deficiency of the fat-soluble vitamins, which includes vitamin A, D, E, and K. Okay, so you have to find out if there is any sign of vitamin deficiency. So what are the signs of vitamin K deficiency that you can find?
Ma'am, joint bleed.
Yeah, there will be spontaneous bruises or any trauma. This kind of finding will be there in case of a vitamin K deficiency. Okay, so
Yes.
why there is a derangement of the coagulation factors in case of obstructive jaundice?
Ma'am, fat soluble vitamin will need bile salts for absorption of those, ma'am. For absorption of those, bile salts will be needed for them, ma'am. If there is no bile salts in the gut, the vitamins will not be absorbed, ma'am.
No. So what is the cause of the deranged coagulation in case of a obstructive jaundice? It is due to. Okay, so there are a lot of causes which is seen in case of a obstructive jaundice. Number one is there is a deficiency of vitamin K dependent factors. Okay, so vitamin K is associated with the final maturation, is associated with the gamma carboxylation of the vitamin K dependent factors, which includes 2, 7, 9, and 10. Okay, so there will be a decreased circulation. Also, when the liver is deranged, there will be decreased synthesis of these synthetic proteins. Okay, there will be increase in the fibrinolytic activity. Also, if it's a case of DIC, there can be cases of this absence of thrombotic agents. Okay, and what will you do to correct the coagulation thing?
Ma'am, if I plan the patient for surgery or else any intervention procedure, I will give injection vitamin K 10 milligram IM for 3 to 5 days, ma'am. If it is not corrected with it, I can introduce fresh frozen plasma to correct the coagulation profile.
Why do you think it won't be corrected by vitamin K? In which situation?
If other clotting factors are affected or not synthesized by liver, I can replenish it with.
So in the case of a liver cell failure, okay, when the liver is itself not working, it can't utilize the vitamin K that you are providing. Okay, in that case, you have to give a fresh frozen plasma. Okay, so you have come with a diagnosis of obstructive jaundice due to carcinoma head of pancreas. So the next question is, how do you proceed?
Ma'am, as an extension of my clinical examination, I will do ultrasound abdomen pelvis to this patient to know the status of CBD dilatation, and then gallbladder to see any focal lesion in the gallbladder, and I will look for any enlarged nodes in the abdominal cavity with ultrasound abdomen, ma'am. And then I will look for liver metastasis or any free fluid within the abdominal cavity, ma'am.
See, if you start with organs, it is very
Anything
easy
else?
to
Ultrasound. Try to understand. Ultrasound is a very good investigation for asthma hepatobiliary tree. You have mentioned good number of points, but some other points are also there which you can.
I can see the dilatation of bile duct also, sir. The
Yes.
double duct sign. I can see the
What
double duct sign with it, sir.
Yes. What else? You have not mentioned about ascites.
Ascites, free fluid in the abdomen.
Ascites. Okay.
Yes.
So you have to understand, you can make out the organ of origin. Okay, you
Yes,
can see the liver status, you can see the gallbladder status, and also in this you have to be relevant to your case. As your patient has a case of as such of a gastric outlet obstruction, so I can make out if there is any thickening in the pylorus, if there is any thickening of the, if there is any growth in the pylorus, if there is any abnormality in the stomach, these all things you can find out. Okay. So next, coming to biochemical investigations, what will you do? Okay, and one thing, if you are asked this question straight away, how do you proceed? You always have to say these three sentences. One is, I will do some investigation to
see the origin of pathology. I will
to
do.
confirm my diagnosis. Next is you can understand you're dealing with a malignant pathology. So you have to stage the disease, okay? And next is I will do some investigation to plan my treatment, okay?
Yes.
So what are the
It's
investigations?
a very good way of answering for any patient. For any patient, if I ask how you investigate, your approach should be, I will do some investigation to confirm my diagnosis.
To
If
stage
it's a malignant disease, I do some investigation to assess the stage of the disease, and then I'll do some investigation to assess the patient fitness for the proposed surgery. So this is the way you start. So if you say confirmation diagnosis, first thing comes is your ultrasound. Fine. Ultrasound corroborates your clinical diagnosis. There is a mass in the head of the pancreas. Double duct sign is present. No lymph nodes are seen in the abdominal cavity.
The
No
liver is clear, there is no ascitic fluid. Okay.
gallbladder is found distended, filled with bile, no stones in the biliary tree. This is the ultrasound finding.
Yes, sir.
So, what do you think you are dealing with? A patient has
Pancreatic
a
cancer.
mass in the pancreatic head. Okay.
Yes, sir.
A mass in the pancreatic head. Can it be anything else other than a malignancy, which may mimic malignancy?
Chronic. It may
Mass
be
in the-
chronic.
Yeah.
Chronic pancreatitis will mimic like
Yeah.
CA head of pancreas. Sir.
How can chronic pancreatitis cause jaundice? Can chronic pancreatitis cause jaundice?
Yes, ma'am. It can cause jaundice,
How?
ma'am. In chronic calcium pancreatitis patient, the patient will also have portal hypertension.
No. So in chronic pancreatitis, what happens? What is the cause of pancreatitis? There is activation of this enzyme,
Recurrent
and there is inflammatory response all over. Okay. So due to chronic inflammation of the distal bile duct, which is continuously because of the pancreatic enzymes, it can cause the fibrosis of the CVD and it can cause a distal obstruction. Okay.
There's a
So
question of CVD at the intrapancreatic part.
yeah.
The intrapancreatic part of the CVD may be compressed. It's more of a compression. Okay.
So
Fine.
just tell me, I am dealing with a case of obstructive jaundice. What will you find in the LFT? Will you like to do a liver function test?
Yes, ma'am.
Okay,
In
so what are the findings I can expect?
obstructive jaundice patient, the total and direct bilirubin level will be raised in the obstructive jaundice patient, ma'am, and then serum alkaline phosphatase level will get raised, ma'am, and then gamma glutarate transcriptase level will get raised, ma'am. 5' nucleotidase level also get raised in case of obstructive jaundice.
What else? You have to do a complete LFT, right? So what does it include? What else do you see?
Liver enzymes, ma'am. SGOT, aspartate transaminase, alanine transaminase, ma'am.
What else?
What else?
Proteins, protein level.
Why protein is important? Why protein estimation in LFT is relevant for a patient of carcinoma head pancreas patient?
If the protein is deficient, we should replenish it before surgery, sir.
What does it indicate? If serum proteins are low, albumin is low, what is this implicating?
Patient is having liver cell failure also, sir.
Yes, as a hepatocellular dysfunction. What is the implication of this low protein, low albumin in planning of my treatment?
Sir, the audio is not clear, sir. Can you please repeat, sir?
What is
If
the
the albumin is low, how is it significant in planning of your treatment?
do you need the albumin to be back to normal before you venture for a surgical treatment?
Yes, sir.
Why?
If the albumin level gets reduced, the post-operative complications will be high, sir.
Yes. Including anastomotic leaks.
Understand?
Including anastomotic leaks will be.
Prepare the bowel, so that you have to prepare the patient like that the albumin should be high. Okay,
Yes,
not
ma'am.
high, it should be normal. Okay.
Yes,
Okay. So coming to so you have done a LFT, and so LFT is not till end. It has been completed. What else? You will see the
PT, coagulation factor.
you will see the coagulation factor, which includes PT, INR, bleeding time, clotting time, and also you will do a in your and what is from LFT? One test, if they tell you, if it's what are the other two tests that is also clinically significant if you do in the earlier stage? You will do a complete blood count and a
Complete
RFT.
blood
Why is
count.
that?
Yes, ma'am.
What
And
do you expect in a CT? What is important to look for?
hemoglobin level, we should look for hemoglobin level, ma'am. It should be more than 9 to operate the patient.
Okay. Okay.
We
So you
discuss
have to
this,
look
but
for
please we can
anemia.
discuss during fitness for surgery. We stick to the relevant diagnostic investigations.
Okay.
Okay.
So what do you do next for diagnosis? Is your diagnosis confirmed in your USG? Are you happy? Will you proceed for your treatment management, or you want to do something else?
Ma'am, I will do staging of the disease, ma'am. So I should do CACT pancreatic protocol, ma'am, to this
What is that?
patient.
So
What
what
do you
is
mean
a
by
It
that?
has 3
pancreatic
phases.
protocol CT?
It has 3 phases, sir. First one is arterial phase. The CT will be taken 40 seconds after injecting dye. In this phase, we can see the arterial involvement of the tumor, arterial encasement of the tumor, sir. In a pancreatic phase, the pancreatic tumor, in arterial phase, we can see is there any neuroendocrine tumor which shows hyperechoic, sir, which is hyperechoic. And then in pancreatic phase, we can see
Hyperechoic,
hyperechoic.
not
No, no.
hyperechoic. Hyperechoic term you use in case of ultrasonography.
Sorry, sir,
Or
hyper intense.
Sir, you just tell me what are the how it is done, because it's not complete.
Yes, sir. First phase is arterial phase, and then pancreatic phase, and third phase is portal venous phase. In
what contrast you use
Yeah.
for this
So
pancreatic
it
protocol?
starts with the it
Oral?
iodine
starts with
contrast,
the
sir. Oral
Oral is what?
what
IV,
oral? What
sir.
oral contrast you will give?
I Hypoic acid, iodine contrast,
That is
So see, so you have
intravenous.
to understand.
Oral,
gastrographin.
No. You don't give gastrographin in case if it's oral in case of a pancreatic
yes.
protocol CT. Okay.
Because if you give gastrographin, what is the problem? If you give the patient gastrographin, how it will interfere with your imaging? Because we want to see the vascular invasion. We
Yes,
want to
sir.
see the vascular in the local tumor. If you give the patient gastrographin, this white contrast will interfere with your vascular imaging. That's why you give a negative oral contrast, either water or mannitol. That you
Yes,
can
sir.
see the duodenum as negative contrast. And
Yes,
how much IV contrast is required for a pancreatic protocol CT scan?
sir. 4 to 6 ml per second, sir.
For how much total board dose?
We should inject for about 30 seconds, sir. Total dose is about 300 to 350.
No, not 350. It's about 100 to 150. The total dose is 100 to 150 ml. And then in sequence, this CT scan is taken in time sequence, as you
Yes.
mentioned, early arterial phase, late arterial phase or parenchymatous phase, and then the portal venous phase.
Space.
And depends on time sequence of 25 seconds, 40 seconds, 70 seconds.
70 seconds.
So
Okay.
it's a
And
64 quantitator helical CT, okay, which is taken from chest to the pelvis, including fine 1 to 3 millimeter cuts, which is taken especially in the liver and the pancreas area till the third part of the duodenum, okay,
Yes, ma'am.
with the oral neutral contrast, which includes water or mannitol, with the IV iodine contrast with a total dose of 100 to 150 ml, which should be injected at the rate of 3 to 5 ml per second. Okay, this is the pancreatic protocol. And what are the imaging time? Just now sir said, can you please
20 up to 20 seconds, 20 seconds, 40 seconds, and 70 seconds, ma'am. 20 seconds for
what are the phases that it is seen?
20 seconds for
Early
early
arterial,
arterial, late arterial, or pancreatic parenchymatous phase, and portal venous phase.
Okay. So now coming to the findings, what do you expect in a venous phase? What do we see?
Liver mets can be seen in this. Liver metastasis can
Liver
be seen
mets.
in this phase.
And what else?
First you talk of this CT is required for number one to assessing the local tumor and assessing the distant metastasis. So
Distant
first talk of the local tumor in CT. What you look for?
I will look for the site of the tumor, sir. Site of the tumor and then extent of the tumor.
Yes.
The pancreatic tumor and portal vein and major vessel relationship. Is there any a clear fat plane between the tumor and vessels?
Yes. What else?
And then I will look for metastasis, sir.
Yeah.
Nodal status. Nodal status. I should look for nodal status, and then I should look for metastasis, liver mets, peritoneal mets.
What is the limitation of a good quality CT scan event to pick up liver and the other intra-abdominal metastasis? What is the limitation?
Peritoneal mets can't be clearly seen with CT, sir. It will be with the laparoscopy.
And liver lesions, how small you can pick up?
Sir, up to 1 centimeter we can pick up, sir.
So
Then
see, if
5
such a
millimeter. Good
question is
CT
More
scan,
than 1 centimeter.
if such
even
a
5
question,
millimeter you can pick up. Now the good CT scan, even 5 millimeter you can pick up. So less than 5 millimeter sometimes cannot be picked up by a Google CT scan. Agreed. So
so if
CT
you're asked is such a question, ki what will you find in the CT? You should go methodically. Like first you have to decide about the morphology. Okay, so the morphology you have to say what is the appearance of the mass that you can see, whether it's a hypoattenuating or hyperattenuating. Okay, next is what is the size, what is the location, what is the status of the pancreatic duct, the status of the common bile duct, if there is any abrupt cutoff, if there is IHPR dilatation. This is about the mass. Okay, next what is very important in CT is the arterial and the venous relation. Okay, so here there will come the question of what is abutment, what is encasement. Okay, and these are the contact and the maintenance of the fat planes. Okay,
Yes, ma'am.
between the SMA, celiac axis, common hepatic artery, on all these arteries and the veins. Okay, next is what are the other things that you can see. If I can see the thrombus in the veins, which includes portal vein or the splenic vein, and what are the extra pancreatic things that you can make out. This includes liver lesions, it includes peritoneal or the omental nodes, and also there can be ascites. Okay, so if you categorize like this, you can answer better in your exam. Okay.
Yes.
Okay.
in CT scan, we have come up with a new group of patient with pancreatic cancer we call as borderline resectable pancreatic cancer. So
Yes,
what are the
yes.
criteria in CT scan to say these are the patients who are now we are grouping as borderline resectable pancreatic cancer based on
Yes.
CT findings?
Yes, sir. Less than 180-degree encasement over the superior mesenteric artery by the tumor,
Yes.
and then SMV portal vein confluence involvement, incomplete SMV portal vein uh, confluence involvement.
One is it can be 360 degree. For portal vein SMB, it can be 360 degree. For supramesenteric artery, it
It
is less
should
than
be less
180
than
degree
180
abandonment.
degree.
What else?
And then common hepatic artery involvement.
Yes. What else?
I
Involved
forget.
gastrodonal artery. Up to that,
Pancreatic,
hepatic artery.
gastrodonal hepatic artery, sir.
And then what about celiac trunk? It should not involve the celiac trunk.
Celiac trunk should
So
not be
these are the
involved.
criteria to define borderline distal pancreatic cancer. Okay, I give you a scenario. This
Yes, sir.
patient underwent CT scan that shows a pancreatic head mass about 4 centimeter. There is no encasement of the vein and the artery, no metastasis seen in the liver, no lymphadenopathy, no ascites, no mental nodules. I give you the CT finding of this patient. How
Yes,
will
sir.
you proceed?
Sir, after correcting the nutritional status and
What is the
relation
CT finding suggestive of what?
it's a resectable tumor, sir.
clinically and radiologically is a resectable tumor.
Yes, sir.
So if this is a scenario, what should be your planning for this patient?
I will plan to do surgery, sir. Whipple's pancreatic adenectomy, sir.
Is plan
After
is
correct.
You shouldn't answer. Whipples is a very major procedure, no? So you can't tell directly that I will plan a surgery. Okay?
Yes, ma'am. After correcting hydration status and nutritional status.
how will you correct? Tell me how will you prepare this patient for this major surgical intervention? What are the different components of preparation for a patient of study jaundice so that you can take this patient for safe surgery?
Sir, to correct the nutritional status, first I will correct the nutritional status, sir, by correcting hemoglobin level. And
How?
then
Hemoglobin level is by blood transfusion, PRBC transfusion. How will you correct nutrition? Patient is already admitted. You cannot.
Plus, you have told that this patient is already vomiting, right? Your
yes,
patient is vomiting. Okay, so one more question. Your patient is vomiting. So you're thinking of a gastric outlet obstruction. What is the biochemical abnormality that we can expect in a case of gastric outlet obstruction?
hypochloremic, hypokalemic metabolic alkalosis, ma'am, with paradoxical aciduria.
Why do they get paradoxical aciduria?
First to compensate chloride chloride excretion by vomiting, the chloride absorption will be increased in the distal tubules, ma'am, so that
Fluoride. Fluoride is a predominant ion you are concerned about.
sir, with the bicarbonate excretion, the sodium also excreted first, sir. With severe vomiting, to replenish the sodium will get absorbed. The sodium will get reabsorbed. Sodium
Which
in water.
hormone is active? Which hormone is
Aldosterone acts on distal tubule to activate the reabsorption of sodium and water, and hydrogen excretion, sir. H plus ion excretion, that is known
you
as a
should answer it.
paradox.
You should answer it very legibly.
Yeah. See,
The
what
answer should
happens
be.
is, in
The
a
answer
case of
should
a
be. I
gastric
give you the answer. The answer
yeah.
should be number one. This patient is vomiting, so patient is losing water. Patient is losing sodium. Patient is losing potassium. So this patient has got a full-blown picture of uh, metabolic
Hypokalemia.
alkalosis with hyponatremia, hypokalemia, and hypochloremia. When this happens, body tries to compensate. And what is the initial compensation? Initial compensation is by losing sodium bicarbonate. So
Yes, sir.
body tries to compensate alkalosis by losing sodium bicarbonate. In that mechanism, you are losing more sodium. So now body sense there is sodium deficit. And to conserve sodium, the aldosterone mechanism comes in. Now aldosterone tries to conserve sodium in the distal renal tubule. How sodium will be conserved? It will have to be conserved in exchange of some positive ions. So in that case, to conserve sodium, body excrete potassium and hydrogen ion. So even on the background of alkalosis, the distal tubule is excreting hydrogen ion because of this gross sodium deficit. That's why patient has cardiac aciduria. Clear? Fine. Next, what are the other specific preparation? One is nutritional correction, one is pallor or hemoglobin correction. What else?
Hydration correction, sir.
Why hydration correction is important? Why hydration correction? These are the patient who is vomiting, patient is dehydrated. If you don't
Yes,
correct the hydration status, what may be the
patient will go
catastrophe
for
in the post-op?
the patient will go for shock, sir. Post-operatively, the patient will go for shock, sir.
Shock means
No,
what?
no. We are not taking the patient.
Hypotension.
We are not. We are talking about pre-operative optimization. Why do you think hydration is important? We have not gone to the post-operative yet.
Yes, ma'am.
To prevent some syndrome, right? What is that?
If the patient is not hydrated well and you take the patient for surgery, these are the patient who can develop post-op renal failure.
Renal failure.
These are the
Okay.
patient who can go to post-op hepatic failure, and we call that as hepatorenal syndrome. So one reason for hepatorenal syndrome is dehydration. So you need to correct the hydration status. What fluid you should give in this patient to correct the dehydration on the background of patient having metabolic alkalosis. What IV fluid you should choose?
Sir, Ringer lactate solution, sir.
Sure, that will cause more harm. If you give the patient Ringer lactate solution, this will cause more harm of the metabolic background. Why? What does the Ringer lactate contains? It contains sodium,
Potassium, sir.
potassium, and lactate. What will happen to the lactate? This lactate will go to liver and convert it to what? Convert it to bicarbonate.
Bicarbonate.
So what will happen?
Alkalosis will occur.
This will worsen the
Alkalosis, sir.
alkalosis. So Ringer lactate should not be given. On the background of outer obstruction, you should not give Ringer lactate. The fluid of choice is normal saline, where you replace sodium and chloride. And when you start giving the patient potassium, because patient will hypokalemia also.
Yes, sir. If the hyponatremia gets corrected, then we should start correcting hypokalemia, sir.
One important point you should note is patient is adequately hydrated.
Adequately hydrated.
The patient is not hydrated, patient is not passing urine, you should not start the patient on potassium. So
what is the best marker for assessing hydration? What is the resuscitation in a shock?
Urine output, ma'am.
Yeah, so it's the urine output that you see in this patient. Okay, so you have not done the complete thing. What is the, how will you complete your, see, you have to be specific to your case also. Okay, you're preparing a case of gastric outer obstruction along with such a jaundice patient. Okay, so what else?
So,
okay, so I will give you a scenario. You just tell me. Suppose this patient has an intractable pruritus. The patient has so much of pruritus that is causing lots of distress to the patient.
yes,
will you go for some
intervention procedure can be done,
what
ma'am.
is
ERCP with stenting.
So you have to tell, I will do a preoperative biliary drainage. Okay, we still don't
Preoperative
the site. Okay, it can be by ERCP, it can be by PTBT. Okay, so you have to tell what are the indications of a preoperative biliary drainage.
The bilirubin level is so high that is more than 20 milligram per deciliter. The patient is having intense pruritus. We can do preoperative biliary stenting.
Okay, so first of all, the level of bilirubin, it is not there anymore. Okay, so it is usually not taken. There are some standards that has been taken more than 15 or more than 20, but usually we don't take bilirubin as a indicator of preoperative biliary drainage. And also the pruritus you said, it is not intense. Okay, that will be a case of intractable pruritus. Okay, so what are the indications? One we have said, intractable pruritus. Next is, what are the indications of biliary drainage? Do you know or should I tell?
Patient having cholangitis, patient having acute hepatocellular dysfunction, you need to wait for surgery for some time. It's a borderline resectable pancreatic cancer. You send the patient, do a US guided FNC, and then wait for the neoadjuvant therapy. In that phase, you need to relieve the jaundice. So doing ERCP stenting is not routine for all patient obstetric jaundice who are to go for Whipple's operation. Okay. What
Any
about
other blood investigation for baseline you want to do if it's a case of pancreatic CA?
I will do tumor markers level.
What tumor marker you want to look for?
CA 19.9, ma'am.
Okay, so CA 19.9, it is important for what? Is it important for diagnosis?
No, ma'am.
Then what are the implications of a CA 19.9?
If the level is more than 100, it denotes the advanced cancer.
Yes, right.
If it's more than 1,000, then it indicates if it's a metastatic disease. If it's more than 100 to 250, usually it is taken as a prediction for doing a diagnostic laparoscopy in this patient. And why it is done? Why do you need a baseline CA 19.9? So that you can follow up the patient, right? You can follow up the patient for any recurrence. Okay, so these are the things. These are the indications of doing a preoperatively biliary drainage. Okay, so you have not completed your patient preparation. One is nutrition. In this patient, where the patient is having vomiting, how do you correct? The patient is not able to take anything orally, as you have said, there is a gastric outlet obstruction. How do you nutritionally replenish this patient?
I will prefer total parenteral nutrition to this patient.
What?
Total parenteral nutrition to this patient.
Yeah.
I will start total parenteral nutrition.
To this patient. Next.
So you should do other investigations to assess the patient fitness for anesthesia and surgery. What are the other investigations you should do?
Sir, I will do ECG, electrocardiogram, and then chest X-ray.
Elderly lady, any other investigation?
Blood sugar level, sir.
Yes. And patient, elderly persons, patient having absolutely jaundice for major surgery should do echocardiography also.
Echocardiogram, sir.
Yeah.
Yes, sir.
Okay, fine. Now you are planning for doing a surgery. Will you plan for doing a diagnostic laparoscopy in this patient, or will proceed straight away for your laparotomy and proceed for Whipple's? Is there any role for doing a diagnostic laparoscopy in this patient, or will you proceed straight away for your surgical intervention?
We can do diagnostic laparoscopy first, sir, to rule out.
What is the rapidity of doing a diagnostic laparoscopy in patient with carcinoma pancreas?
To rule out the metastasis, sir, that is not picked by CT, we can do it, sir, and then
we can find out subcentimeter peritoneal and the omental metastasis.
Sir.
That we have to understand, and suppose we have given a peritoneal washing and we can see there is positive cell. So what will be the stage of this disease?
Advanced stage, ma'am, stage 4.
Yeah.
It's M1 if the peritoneal washing has come out to be positive. Okay. So suppose we have started with a so we have adequately replenished the patient. The patient has been admitted and so no need of any preoperative stending. We are starting operation for this patient. Is there any specific maneuver that you want to do first?
SMA first maneuver we should do, ma'am, first.
Okay, and why is that?
If we find the tumor involvement to the SMA, we can abort the procedure, ma'am. It's a stage of unresectability, so we can abort the procedure.
How do you approach the SMA?
Okay, we go step by step. You have now decided to do a diagnostic laparoscopy. You put the scope. You find there are small peritoneal deposits and very small liver deposits.
Yes, sir.
What should you do at this stage? Patient on operation table.
Sir, it's a stage of unresectability, sir. If metastasis is there, we should not go for resectability.
In this patient? This patient with these features, you have this finding of small liver and peritoneal metastasis. What should be the next step in this patient?
Sir, to relieve the obstruction and
yes,
biliary stasis, we can go for triple bypass, sir.
Triple bypass. What does the triple bypass includes?
Sir, it includes gastrojejunectomy and then cholecystectomy and then ciliary blocks, celiac block.
Celiac block is not a bypass. You say triple bypass. And a jejunectomy. You lift a roux loop. You do hepaticotocojejunostomy, gastrojejunectomy, and a jejunectomy. That is a triple bypass. Okay. Yes. And then if the patient having pain, you should consider doing a celiac pressure blockade. Okay. Yes, and now another scenario is there is no peritoneal deposits. You can find a mass in the pancreatic head area, no peritoneal deposits. And you are an open surgeon. You decided to open it up. Yes. Now you opened. How will you proceed to decide that yes, this is a resectable situation and you will proceed for resection? What are the salient steps?
Yes, sir. With the I will open the abdomen with rooftop incision, sir, and then after entering the abdomen, I will incise the transverse mesocolon and then enter into the lesser sac to see the.
You will go to the mesocolon. You don't go to the mesocolon to the lesser sac. What is the first step as you go? What is cattle brush maneuver?
Cattle brush maneuver, sir.
What is that?
Placing the Right colic
Yes.
flexure by
What is right
incision.
colic flexure? Right colic flexure is overlapping the second part of duodenum and the pancreatic head.
Yes, sir.
So you bring down the right colic flexure down. Number one. Next
Yes.
step is what?
To
What is the cauterization of duodenum?
coccorization, sir. Coccorization of the
Yes.
duodenum, sir.
Why do you caugarize the duodenum?
Sir, to look for portal vein
Caugarize.
status, sir.
Once you caugarize,
The
what
pancreatic is
structure
also move, sir. Will
what
also move.
structure is there behind your,
SMA, sir.
not SMA
Yes, sir.
first,
Portal vein.
is inferior vena cava. As you leave the during the pancreatic head, inferior vena cava. Sometimes the large tumor can infiltrate into inferior vena cava. You
Exercise
stop there. You cannot
unresectability.
go.
Yes, sir.
So you do a extensive cauterization,
Yes,
and
sir.
then you reach the SMA.
Yes, sir.
Okay. So cauterization duodenum. Next step is what? Cattle brush, cauterization. Next step is what? Because you have not yet decided whether to proceed for resection. Do you
Yes.
specifically try to find out any node in the abdomen which may decide that is inoperable situation?
Sir, iliac para-aortic node, sir.
Iliac
Para-aortic.
node, iliac node is for pancreatic cancer. You don't go to iliac node by
Para-aortic
supposition.
nodes.
What para-aortic? Which specific node is important, and that node is found you are significantly enlarged. You should resort to something and wait before you proceed. What is that node?
Sir, node around celiac trunk, sir.
No, node
Door
celiac is resectable. If you have a aortocaval node,
aortic
there is a fixed node between the, as you caugarize the duodenum and the pancreatic head, you lift up, you find the aorta and the IVC. There is a node in between the two major vessel, which is known as aortocaval node. If aortocaval node is significantly enlarged, you should take this node out and send for frozen section biopsy.
Yes.
If it is positive, what is the inference? Positive aortocaval node means it's an advanced disease.
Yes, sir.
It's an advanced disease and the resection is not indicated. We will not do a resection. We do a palliative surgery. So that is the node you should first check. Okay, no aortocaval node is enlarged. Now you are proceeding. What do you do next? Just salient steps. We are not asking all the steps.
Yes, sir. I will ligate and dissect the gastroduodenal artery to.
No, you cannot do. You have not decided yet that you are in a resectable situation. You cannot straight away ligate the gastroduodenal artery. What do you do from
Sir,
below?
I will.
From below, what do you do?
Sir, I will check is there any tumor involvement over the portal vein, sir. Tunnel of love should be
Yes.
checked.
So next step is you try to see whether you can make a tunnel between the portal vein and the pancreatic neck from below.
Yes, sir.
From below you can go up towards that side. Yes, this is a situation that there is no invasion to the portal vein.
Yes,
And
sir.
then you go up. From the above, what do you start? You start where? You cannot straight away find the gastroduodenal artery. You cannot find the gastroduodenal artery straight away.
Gastroduodenal ligament, gastrohepatic ligament should be excised.
Yes, you have to first divide the gastrohepatic ligament from the liver. You bring it down. You dissect the hepatic artery proper.
Yes, sir.
Where do you find the gastroduodenal artery? Where do you find the gastroduodenal artery as you dissect the hepatic artery proper? Where is that? What is the guide to reach the gastroduodenal artery?
The node, sir. The node along the common hepatic artery.
It's not the node. What do you find? Where is the genu? Where is the genu of the common hepatic artery? The common hepatic artery runs along the upper pancreas and it goes upward. That genu is the area where the GD arises. So you trace the hepatic artery proper, and as it bend towards the upper pancreas, that bend is the area where you find the gastroduodenal artery. So you find the gastroduodenal artery, and now you can divide the gastroduodenal artery. What structure is lying behind that?
Portal vein, sir.
Portal vein, yes.
And
So
also,
now
you shouldn't ligate the gastroduodenal artery directly. You should always check for the distal patency, and then only you should ligate the gastrointestinal artery. That is very important step.
And sometimes right hepatic artery may arise from the gastrointestinal artery. So in that case, you should clamp the gastrointestinal artery and find whether there is any blanching in the liver. So exclude there is no abnormal biliary arterial anomaly. So you first apply a clamp and see. If it is not there, now you have the triphasic CT scan, you have a angioplate also. So you know beforehand there is an anomaly in the hepatic arterial tree or not. So once you ligate the gastrointestinal artery, now you can make the complete tunnel. Now tunnel has been made, you decided that you are going to resect the tumor. What are the broad steps?
Just tell us what are the structures are resected and what are the anastomosis done.
We should remove head of pancreas up to 1 necrosis level, and then whole of the duodenum and proximal 10 centimeters of jejunum, distal 40 to 50% of stomach, and then distal, and then whole of CBD, common bile duct with gallbladder.
Okay.
What about the unseen necrosis?
We should remove it, sir.
Yes. Pancreatic head along with the unseen necrosis. Okay, you have to remove this.
What is the anastomosis done?
First, we should do pancreatico-jejunostomy anastomosis, and then 15 centimeter away from that, we should do hepatico-jejunostomy anastomosis, and then gastrojejunostomy anastomosis.
So last 5 minutes.
Yeah. Okay, so in a case of a borderline this is a case of resectable pancreatectomy, that resectable case. What do you do in a case of a borderline resectable pancreatic disease?
First, I will introduce neoadjuvant chemotherapy to this patient to downstage the disease.
No, you cannot initiate. A borderline resectable pancreatic cancer is a diagnosis based on imaging.
Yes, sir.
Nobody
First,
in a
we should confirm with the HP, sir.
Yes, how do you get the HP?
Sir, FNAC, FNAC or endoscopic ultrasound guided FNAC, we can confirm the diagnosis, sir.
Yes.
After that, we should.
How endoscopic ultrasound is superior in assessment of pancreatic cancer patients?
Yeah. How is EUS relevant in diagnosing a case of obstructive jaundice?
Ultrasound, endoscopic ultrasound.
Yes. Because you have other, you have MRI, you have CT, you have ultrasound. How EUS is scoring more?
It is side viewing endoscope. With it, we can visualize the tumor and its relation to the tumor relation to the duodenal wall, and we can see ample of water clearly with this.
So we can see the relationship of the tumor with a major vascular structure. So also EUS is very sensitive for picking up subsegmental lymph nodes. Okay.
Yes,
so this is important, and also we can take EUS guided FNA. Okay, and also brush cytology from the distal CBD. These are all important. So in case of a borderline resectable, you have to understand we cannot directly offer the patient a neoadjuvant therapy without confirming my diagnosis. So what are the indication of FNA? Do you need a FNA before?
Tumor is unresectable, we can do FNA.
Not only unresectable, even if it's a borderline resectable or a locally advanced. Okay.
Yes,
if it's when we are giving a patient the neoadjuvant treatment, we have to do a FNA. Okay. Okay. So what is the drug of choice? What is the chemotherapeutic agent that we use as a neoadjuvant treatment?
5-fluorouracil, gemcitabine.
Usually it's a gemcitabine based chemotherapy. You add other drugs also, but it's a gemcitabine based chemotherapy acts well in this pancreatic malignancies.
So previously there was a concept of gemcitabine monotherapy, but now the trials have come up that the preferred regimen is FOLFIRINOX plus minus chemoradiation, and also if you are using gemcitabine, we use gemcitabine with cis-paclitaxel. Okay, this is the with cisplatin. Okay, so this is the preferred regimen. Okay, so how do you follow up a case of neoadjuvant therapy? You have given the patient a neoadjuvant therapy then.
And then I will go for surgery, ma'am. After downstaging the tumor to resectable stage, we can go for surgery. We can go for resection.
Okay, so we will do what criteria will you use to understand the progression or the recession?
And I can't get your question.
What is the criteria used for restaging? It is the RECIST criteria. Okay.
Once you are downstaging, how do you restage the patient to decide whether you should go for surgery intervention or not?
Okay. I don't know, sir.
RECIST criteria, response evaluation in solid tumors.
Yes, sir.
Okay, so you have done Whipple's procedure. How do you take care of this patient in the post-op phase? What are the specific post-op management in a patient who has got a Whipple surgery being done?
Sir, we should check the urine output post-operatively.
Before
We should
urine output,
monitor.
many things. Urine output is one parameter for assessment, agreed. But
Yes, sir.
urine output is not the only thing you jump on. Patient underwent a very major surgery. Why do you like to treat the patient in the post-op period? In the general ward?
No, sir, in ICU, sir.
In
Surgical ICU, sir.
ITU for initial few days. So
Yes, sir.
this patient needs monitoring. So this
Yes, sir.
patient will be taken care in the post in the intensive therapy unit. What
Yes,
are
sir.
the things you specifically see in a patient who has undergone such a major surgery?
Sir, I should monitor. I should. I
Talk
should
of
monitor
IBP.
pulse rate and BP level regularly, sir.
So first is the monitoring of the patient, and specific treatment in the post-op period is the most important is intravenous fluid therapy.
Intravenous fluid.
Okay, so plan a rational intravenous fluid therapy. If the patient has got good amount of blood loss, you should consider about giving some PRBC transfusion.
Yes, sir.
And then what about antibiotics?
We can give third generation cephalosporin, sir.
Huh?
Third
Is
generation.
antibiotic required in a patient who underwent surgery for obstetric jaundice?
Sir, antibiotic should be given, sir.
Yes. What antibiotic should be the your choice?
Third generation cephalosporin, sir.
Only
With aminoglycosides.
because you see bile contains all flora. So while doing intervention in this patient, you should give antibiotic. You should cover all the gram-positive, gram-negative bugs, including bacterides.
Yes, sir.
The antibiotics because these are the patient who may have chronic gram-negative septicemia. What else?
Have you seen a Whipple's?
Yes, ma'am. I have assisted 2 cases, ma'am.
Yeah. So what do you look for? Suppose you are a third year, you have gone for the rounds. What all you check? You have said pulse, BP.
I will check drain amount, ma'am.
Yes.
Yeah.
Very important.
What is the drain content?
What is the nature? What is the color? What is the content? Okay.
You find a patient in the Kavi, you find a post-op patient in the ward, and in the evening you find patient in shock. Patient has got very low blood pressure, and you find about 300 ml of blood has come to the drain. What should you do? What do you think has happened? Is a very common scenario in
Yes, sir.
patient having Whipple surgery being done. What might have gone wrong?
Sir, any slippage of knots over arteries. We should reopen the case, sir.
You see, reopening is a decision that is different. Whether you need to reopen a patient of bleed should be decided number of things. So the scenario is patient has a bleed.
Yes, sir.
And patient is shock. So first thing is to resuscitate the shock.
Yes, sir.
And in the meantime, you have to prepare the patient. In the it's not that you will wait for the OT to start resuscitating. In hemorrhagic shock, the primary management is not resuscitation. It is resuscitation along with control of the hemorrhage. Okay, both of this it should go simultaneously. Okay, so this last question: what is the definition of pancreatic fistula? Post-operative pancreatic.
First, how do you define a pancreatic post-operative pancreatic fistula?
Sir, it is a pancreatico-cutaneous fistula.
Yeah. It's not. You have a drain. It's
Yes,
not
sir.
coming to the skin. You have a drain. So you are finding something coming to the drain, And when do you say it is a situation of pancreatic fistula?
The drain contains high level of serum amylase, sir.
How high? How high?
More than 1,000.
Huh?
More than 1,000, sir.
No.
There is a grading for that, but what is the definition?
How do you define a posterior pancreatic fistula? There is a clear definition for that. Any measurable drain output on the third post-op day,
Yes, sir.
and this drain fluid amylase is 3 times the normal amylase. We call that as pancreatic fistula. So you should be knowing about grading of pancreatic fistula and their treatment. I think Priyanka, we have covered. Sir, Srinivasan sir?
No, sir, you have to judge my students, sir. Covered in detail by both of you. And she has answered most of the questions Priyanka has.
Very well, very well. She's very good.
She will cover it up by the for exams. We'll make you.
Sir, thank you so much, sir. Thank you, ma'am. I learned so many new points, ma'am, with this presentation, ma'am.
Yeah, sir said learn about fistula because postoperative pancreatic fistula, the incidence, how do you grade it, and how do you find it, and how do you treat it? Okay, so that will be a question. Even the steps, some examiners say that they'll skip the steps and ask for postoperative Whipple's complication. Instead, we are hearing about Longmire's operation. What is that? And a lot of things, new things have come up. So postoperative complications, they follow up. As a postgraduate, you should know the follow-up and how to manage the complication. You read it up because some examiners will ask.
Yes.
By the by, Prabha, you are saying Whipple's operation. Do you know the operation you are doing now is not exactly Whipple's. This is modified Whipple's operation. What is the original Whipple's operation? You know what Whipple's did long back?
Sir, it is a double two-stage procedure.
Stage.
It was done as
What was the first stage he did?
Sir,
What the first stage operation Whipple's did?
first he resected the tumor, sir.
No, first is not section. Patient, this was very poor. What he did a gastrojejunostomy and cholecystogastroscopy. And once the patient has improved, once the jaundice improved, he has gone for the resection. So that was the original Whipple's. Who modified the operation? Who first did the one-stage pancreatonectomy?
Sir is asking classical. I wanted to ask that question. Who did the first pancreatectomy?
I forgot the name of the.
Actually, there are two people you should never forget in surgery. One is Theodore Cocker. The other one is this man. Now tell who is he? Concerned with breast. Concerned with breast. Halstead, William Stewart Halstead was the man who did the first pancreatectomy.
Yes, sir.
This Whipple modification is by Trimble. Trimble. What is pylorus preserving pancreatonectomy? What is the rationale behind that?
Sir,
now, another modification by Longmire, we call that as pylorus
preserving
pancreatonectomy. What is the rationale?
Sir, by leaving the pyloric antrum, we can avoid the dumping syndrome.
You described, you said you will take 40 to 50% of the distal stomach.
Yes, sir.
So
in pylorus procedure, we will remove the we won't remove the pylorus.
Yes.
2 centimeter distal.
So you avoid complications of gastrectomy. You avoid complications of gastrectomy. So that is the modification. What is the why people are not doing routinely this procedure? What is the problem of pylorus preserving pancreatonectomy? Sometimes you may have prolonged ileus. Sometimes you have prolonged ileus following pylorus pancreatonectomy, but most of the time it resolves. Yes, Srinivasan sir, I think we should stop.
Yes, sir, we can, sir. Aishwarya?
Yes, sir. Thank you, sir. It was indeed a comprehensive clinical class. The discussion was very useful for us. Thank you so much, Professor M.L. Saha, sir, and Dr. Priyanka Saha, ma'am, and Professor Srinivasan, sir, for teaching and guiding us. We are ever grateful to you, need your blessings, guidance, and support throughout. It was a great effort by the presenter, Dr. Kaviprabha, ma'am. We could learn a lot because of your well-prepared presentation, ma'am. Thank you so much. We also thank all the participants who are enthusiastically answering and were actively involved. Thank you, one and all.
Thank
Priyanka,
you. Thank you to the
Thank you.
faculty and also thank you, Kaviprabha. Excellent presentation.
Thank you, ma'am. Thank you, ma'am. Thank you, sir.
Especially to Priyanka, because you attended the exams recently. So
Yes, sir.
you said in a systematic way. I think the PGs are listening. They should start. They said just USG. I look for that radicals and other things. They will not say where is this origin of organ, then how to go in a stepwise way. You made it correctly. Very, very good. Thank you.
Yes, ma'am. With your explanation, I learned a lot, ma'am. I won't forget those tips, ma'am.
Okay, thank you.
Yes, ma'am.
Thank you.
Thank you. We can.
Thank you, Prabha.